Today we'll discuss about cardiovascular trials and diabetes management updates. My agenda is diagnosis of diabetes mellitus, pre-diabetes, cardiovascular risk assessment in patients with diabetes mellitus and pre-diabetes. Number 3 is prevention of cardiovascular disease in patients with diabetes mellitus and pre-diabetes. Number 4, clinical trials and diabetes management. How to diagnose diabetes mellitus? It's a brief revision for diabetes mellitus according to ADA 2019. We diagnose according to HbA1c more than 6.5% or impaired glucose tolerance. The 2 hours postprandial is more than 140 to 200 milligram per deciliter. And it is recommended from diagnosis from the guidelines to diagnose diabetes mellitus according to HbA1c, and better form OGTT is used for the diagnosis of diabetes according to class 1A. As well as we know that there is limitation of HbA1c to be considered, such as interference as a result of hemoglobin variant and anemia, as well as acute coronary syndromes. Also, OGTT should not be performed earlier than 4 to 5 days to minimize false positive results. Cardiovascular risk assessment in patients with diabetes mellitus, it's very important to all physicians to put the patient in cardiac risk stratification from the first visit. According to this risk stratification, we know that very high risk patient is the patient with diabetes mellitus and established cardiovascular disease. Other target organ damage plus other organ target damage, or more than 3 factors, risk factors, or there is onset of diabetes mellitus very early, long term than more than 20 years. الهاي risk patient هم diabetes mellitus more than 10 years and without organ damage plus any additional risk factor. أما moderate risk هم patient type 1 diabetes mellitus less than 30 years, aged less than 50 years, or with diabetes mellitus less than 10 years without any risk factor. So routine assessment for microalbuminuria is a class 1 indication for these patients to risk stratify developing of renal dysfunction and organ damage, as well as resting ECG is very important. Class 1C is indicated for the patient diagnosed with diabetes mellitus with hypertension with suspected of cardiovascular disease, and assessment of carotid or femoral plaque is class 2A as a modifier factor. And the calcium scoring for the coronaries is most risk modifier as well, class 2B. And ankle brachial index also, it is risk modifier for cardiovascular risk assessment. Carotid ultrasound and the intra-intermediate thickness is contraindicated. Meta-analysis of 5 randomized clinical trials with the 3,299 asymptomatic subject for diabetes mellitus show with that the non-invasive imaging and the coronary artery disease don't significantly reduce the events rates of non-fatal MI and hospitalization from heart failure. According to routine screening is important in coronary artery disease for asymptomatic diabetes mellitus, and it is not recommended. However, stress testing of coronary angiogram or CT scanning for coronary may be indicated in very high risk patient asymptomatic individuals. So cardiovascular risk stratification is very fundamental, and in diabetes and pre-diabetes patient, as well as individuals without cardiovascular diseases who have pre-diabetes warrant risk of scoring cardiovascular disease in the same way. Based على score system, CKD, familial hypercholesterolemia, other risk factors, cardiovascular. This is again from the guidelines, how we can risk stratify our patient. Number 3, which is very important, is prevention of cardiovascular diseases with diabetes mellitus and pre-diabetes. How to do that? By lifestyle modification, glycemic control, blood pressure monitoring, and management of dyslipidemia and antiplatelet. By smoking lifestyle, decrease in body weight, physical activity, and diet. as well as we should good control and glycemic control for the diabetes patient for reduce the microvascular events. HbA1c should be less than 7%, as well as HbA1c class 1c to be individualized for the patient with comorbidities and prevent weekend avoidance of hypoglycemic attacks. Also, self-monitoring is very important by the scanning by the mobile or by sensors nowadays. HbA1c less than 7 is very important for as well as macrovascular complications. So HbA1c target less than 6.5% is very important. Considered in individual basis can be achieved without hypoglycemia, and also HbA1c less than 8% or 9% in elderly patient with advanced comorbidities, hypoglycemia predisposed for ischemia and arrhythmias. Number 4, clinical trials and diabetes mellitus management. Classification of anti-diabetic medications, as we know, insulin sensitizers, insulin providers like insulin sulfonylurea, and incretin-based therapies like GLP-1 agonist, DPP-4, and GIT glucose absorption inhibitor, acarbose, renal glucose reuptake inhibitors like SGLT2 inhibitors. Incretin are GIT hormones that stimulate insulin release from the pancreas that include the GLP and the GIP. These hormones are metabolized by DPP-4 enzyme. So what are the guidelines telling us about type 2 drug naive patient for diabetes control? According to guidelines, atherosclerotic cardiovascular disease, it is in the level of high or very high or cardiovascular event or multiple risk factors. The patient is categorized as very high risk. Plus all of these, we should add for them SGLT2 inhibitor or GLP-1 receptor agonist as monotherapy. If uncontrolled, we will add metformin. If not controlled, we will shift to another categories, SGLT2 or DPP-4 or sulfonylurea or insulin. If the patient is a naive patient and no evidence of cardiovascular risk or there is no multiple risk factors, we can start with metformin therapy, and if not controlled in the visits, next visits, we can add or shift him to another categories. Type 2 diabetes mellitus on metformin patient, if the patient is very high risk or high risk, we add the SGLT2 inhibitor or GLP-1. Or if not evident for this patient, we will continue for them as metformin monotherapy. If not controlled HbA1c, we will add to another categories like DPP-4, GLP-1, SGLT2, or DZTs. So our recommendation as class 1 indication, empagliflozin, canagliflozin, dapagliflozin, to reduce the cardiovascular events. Empagliflozin is very important. It reduces the risk of death, as well as GLP-1 receptor agonist is liraglutide, semaglutide, dulaglutide are very important to very high risk or high risk patient to reduce the cardiovascular events. Biguanides are class 2A and insulin is class 2A. It's very important also in acute coronary syndrome. And the saxagliptin DZDs are contraindicated in patients with heart failure. So benefit of SGLT2 inhibitors versus GLP-1. How we can tell the patient what is the benefit from this to him? It's important in reduction of heart failure hospitalization. Recurrent hospitalization is decreased by the empagliflozin or dapagliflozins for these patients, but are same in mortality benefit and renoprotective effect, lowering effect and BP lowering effect and weight reduction. So our recommendations of cardiovascular from ESC guidelines, treatment with SGLT2 inhibitors, empagliflozin, canagliflozin, dapagliflozin is class 1 indication for renal endpoints and HFR 30 to 90. And treatment with GLP-1 receptor agonists are important to lower the risk of renal endpoints, and it is in the treatment till eGFR more than 30. Landmark trials that show the cardiovascular benefits of SGLT2 inhibitors are in empagliflozin is EMPA-REG. dapagliflozin, declare, and dapa heart failure, cangaflozin, canvas, and recredence, semaglutide, sustain, albiglutide, harmony, liraglutide, leader, dulaglutide, rewind. Landmark trials in DDP4 inhibitors neutral as regard to cardiovascular safety except staxagleptin, like sitagliptin, ticus, and linagliptin, carmelina, carolina, allogliptin is examined, saxagliptin, savertimi, 53, it is increase in heart failure, so it is contraindicated in heart failure patient. According to guidelines, we know that the diabetic patient only for the anti-diabetic patient, anti-diabetic treatment only, but we should risk stratify the patient and control for him the other risk factors like blood pressure. So antihypertensive medication and the treatment should be started if the patient has multiple risk factors and considered as moderate or high risk, should be more than 140 over 90. We should start the medication for him, not only lifestyle change, and this class 1 indication. And the patient PB goal is very important to reduce to be 130 or decrease than 120 over diastolic blood pressure less than 70. So it is very important in the treatment of control blood pressure, not only lifestyle change as is a class factor A, as well as we should start medication and be aggressive and to reach the target control for the blood pressure by ACE inhibitor or ARB plus combination with calcium channel blocker or diuresis like hydrochlorothiazide. And for the another patient benefit of different blood pressure target, systolic blood pressure 140 less than 140 or diastolic blood pressure less than 90, it reduction of stroke, coronary events, and kidney disease. Systolic blood pressure from 131 to 135, it reduced the risk of all-cause mortality by 13%. Systolic blood pressure less than 130 is greater reduction in stroke. So management of dyslipidemia as well as a risk factor and the risk factor modifier in diabetic patient is very important. Class 1 indication to moderate cardiovascular risk LDL. It's very important, 3 numbers. Moderate cardiovascular risk, the patient should be less than 100 milligram per deciliter LDL cholesterol. A very high risk patient less than 70 milligram per deciliter. A very high risk patient with cardiovascular event less than 55 milligram per deciliter, it is class 1 indication. According to non-HDL cholesterol, is very important to be less than 85 for the very high risk and 100 milligram per deciliter in very high risk cardiovascular event. Statins are recommended as to the first choice for the control of hyperlipidemia, as well as we can add ezetimibe if the patient is not tolerated to high dose statin and should go to the target number of LDL cholesterol. In very high risk patient cardiovascular events, we can also start PCSK9 inhibitor. It is recommended if the patient is not tolerated to statin. According to antiplatelet therapy, the trial of Ascent aspirin 100 milligram per deciliter per day, it's a benefit from reduce the risk of serious cardiovascular events and increase the risk of major bleeding and reduce the risk of cancer. No, there is no evidence from this trial. So conclusion, primary endpoint in MI ischemic stroke, TIE cardiovascular, reduced by 12%, but counterbalanced by 29% increase the risk of the bleeding. The antiplatelet is very important as class 2B, not class 1, in high and very high risk patient, and it is contraindicated in moderate risk, and we should give them more proton pump inhibitor in this medication. Summary of the treatment targets for the management of the patient with diabetes mellitus, as we know, blood pressure control, glycemic control, HbA1c, lipid profile by LDL cholesterol, platelet inhibition, smoking, and the lifestyle modification by weight and dietary habits is very important. I hope it is very brief and very simple, and thank you.